Hello everyone and happy holidays. Welcome to our monthly Interqual Education, a series designed to be both informative and brief to ensure that we nail the right level of care for some of the most high-yield diagnoses that we see in our network every time they come through our doors. Let's get started. December is AMI month. That's right. What's more angina-inducing than chasing the door-busting insanity of November's end with the sequential family get-togethers, gift shopping, and flu season to boot that December has to offer? This talk will not go into the critical care criteria for an acute MI. I think we're all fairly comfortable with the fact that an MI with an unstable arrhythmia that requires cardioversion, pressors, or ROSC is going to meet inpatient criteria. Today, we'll focus on 1. Knowing what is required in order to admit an ACS rule-out as observation, and 2. What you need in your diagnostics and documentation to meet inpatient criteria for ACS. As always, we'll start with where AMI is located on your badge buddies. If you don't have a badge buddy by now, please reach out to your site's leadership team to ensure you get one since they're so helpful. And here we are, spelled out for observation and inpatient criteria. Let's take a closer look and focus on the key points. Here is a brief flowchart I've organized for observation criteria. Nothing too unexpected, I hope. You start out with your patient who you suspect has cardiac chest pain, so you order the chest pain workup. For those of you who wonder what a chest pain workup is, I like basic labs, a troponin, chest x-ray, and an EKG. BNP and D-dimer are sometimes added based on the presentation, vital signs, and risk factors of the patient. You then find that the EKG is negative for ischemic changes, and your initial troponin is within normal limits. However, your patient is elderly or has significant risk factors and you just can't justify sending them home, so you want to admit them for an OBS stay. Therefore, you order your second troponin and make sure you time it to an appropriate hour, and then you call for admission for observation. Also make sure that you hit your decision to admit after you've ordered the second troponin. This won't be an issue when we move to high sensitivity troponin, which is right around the corner. For high sensitivity troponin, the observation group will be the group that may have a mildly elevated troponin that does not increase on the timed delta. In such a case, you won't call for admission until you have both sets back. Also, for those of you who are calling for admission on an anginal equivalent for chest pain ACS rule-out, there are rules regarding the patient's age, so be mindful. If male, an anginal equivalent OBS stay for something like dyspnea can only be done at or above the age of 40, and for a female, at or over the age of 50. For inpatient, there are a couple of different pathways to consider. If you identify a STEMI on EKG, you're done. That patient gets admitted or transferred for PCI as inpatient. Alternatively, to meet inpatient criteria, you can diagnose NSTEMI or document unstable angina because the patient is at rest and still having chest pain or has treated unstable angina. These are the patients who have presented sitting on the couch watching television, who started having chest pain and then got aspirin or nitro en route from EMS and now feel much better, along with either an EKG with ischemic changes or a new left bundle. If you don't comment on EKG changes or they don't have EKG changes that are ischemic in nature, then you can risk stratify them identifying a high heart score. What's the heart score? Here is the heart score. We'll be using this in conjunction with our high sensitivity troponin soon, so getting familiar with it is a good idea. A low heart score is 0 to 3, a moderate heart score is 4 to 6, and a high heart score is 7 to 10. Remember, we admit patients for inpatient with a high heart score of 7 to 10. You must use one of the two shown pathways for NSTEMI or unstable angina to meet criteria for inpatient admission. One final note, everyone, don't forget to treat these patients. Give them aspirin in the emergency department as long as there isn't a contraindication, and discuss anticoagulation with your cardiology consultant or admitting hospitalist partner. Remember that sometimes the simple mistake of not ordering treatment prior to admitting orders or the decision to admit can cause the patient to be assigned an inappropriate level of care, which means greater financial burden on them and difficulties for the hospital and our case management team. That's it. Thanks for watching. Have a happy winter, enjoy the cool air, and stay safe.